Welcome, everyone. We will get started shortly. We're just going to allow everyone to join the meeting. All right, so we'll get started. Once again, welcome and thank you for joining us tonight. My name is Bridget Roman and I'm a fourth-year student at SUNY and the current CE Work Study Assistant. Tonight, we will present the final part of Building an Inclusive Practice Series, Beyond the Exam, Practical Ways to Improve Patient Access to Care. If you missed any of the past programs, you can go to www.sunyop.edu/CPE to watch any of the past webinars. We hope that you have enjoyed this series thus far and will join us at Envision New York, the hybrid conference scheduled for October 22nd to the 24th. Registration is now open. So here's a few of the CE housekeeping notes. The webinar is being recorded and will be made available within the upcoming week. The program is scope approved for 2 hours of CE credit. To earn credit, you must be logged on during the entire 100 minutes of the lecture, and attendance is monitored by timestamp reports provided by Zoom. In the event you are disconnected, just try to log back in right away. The certificates will be sent via email in 2 weeks and will be reported to ARBO and COPE. Questions for the speaker, just enter them in the Q&A box, and any CE or technical questions you have, enter them in the chat box as well. On behalf of the CE office, I would like to thank you all for your participation in the program. All right, so now I would like to introduce the course director, Dr. Joy Harewood. Dr. Harewood is the inaugural director of Diversity, Equity, Inclusion, and Belonging, and an associate clinical professor of SUNY College of Optometry. She graduated from UC Berkeley School of Optometry and completed a residency in ocular disease at SUNY College of Optometry. She has achieved a fellowship of the American Academy of Optometry and is a current diplomat in the American Board of Optometry. She has extensive experience in hospital-based eye care and has taught optometry and ophthalmology residents in clinical and didactic settings. So Dr. Harewood can take it away.
Thank you, Bridget, and thank you everybody for coming tonight. I'm actually going to introduce my co-lecturer, Dr. Asha Tadapolu. She graduated optometry school from the Massachusetts College of Pharmacy and Health Sciences in May of 2020. She was accepted to the SUNY-affiliated primary care and ocular disease residency at Bronx Care Health System and completed her year in July of 2021. She also achieved her diplomate status in the American Board of Optometry. She continues to provide care at Bronx Care Health System as faculty because she was so good they couldn't let her go. So tonight's lecture is titled Beyond the Exam Room, Practical Ways to Improve Patient Access to Care. And the real point of the lecture is to help define and identify barriers in access to care and provide you with practical ways you can improve your patients' lives to get over those barriers. We have absolutely no financial disclosures. We will be mentioning some different websites and places that you can use in order to help your patients, but we are not getting any money from any of them.
All right, good evening, everyone. I just wanted to start out by reviewing the course outline for tonight. We'll be introducing ourselves and then reviewing the common definitions and social determinants of health. We'll go over optometry's role in caring for underserved populations, barriers and access to care, practical approaches to address eye care barriers, and finally, outline some resources that we can use outside of the exam room. So a little bit about ourselves. I'll have Dr. Harewood go first.
So I'll tell you a little bit about myself in order to kind of ground you with the lens from which I teach this course. I was born and raised in Ottawa, Canada, to parents who immigrated from the West Indies. Canada obviously has universal healthcare. So in terms of my experience with insurance and healthcare, it has been quite varied. After living in Ottawa for a number of years, I moved to Toronto to study both biology and genetics. And then I moved to California in order to do my optometric degree. After that, I crisscrossed the country again, coming to SUNY for my ocular disease residency. When I finished that residency, I started working in Staten Island. For those of you who get this next picture reference, I appreciate you. So when I worked in Staten Island, I was really working, at Staten Island University Hospital, doing outpatient care and taking consults and inpatient care. My outpatient clinic was largely made up of patients who were uninsured. So there were a number of patients who either had insurances that didn't cover a lot of things, and I actually treated a lot of undocumented immigrants, as well as people who I really had to get creative with in order to get them coverage and get them care. So that gives you an idea as to why I find this so important to teach to you tonight. After working in Staten Island, I moved to work in the Bronx at Bronx Care Health System along with Dr. Tadapuli. And there I supervised optometry and ophthalmology residents teaching the clinical and didactic program, as we said. And there, as you know, Bronx Care Health System used to be the Bronx Lebanon. It is in the South Bronx, and there is quite an underserved and vulnerable population, some definitions that we're going to get into in just a few minutes. Finally, I moved back to my alma mater, which is here at SUNY, as the inaugural Director of Diversity, Equity, Inclusion, and Belonging, but I also do have quite a bit of clinical time, so I'm able to utilize some of the things that I'm teaching you tonight in my clinical care.
All right, so a little bit about myself. My name is Asha Tadapuli. I was born in India and I immigrated with my family to Illinois at a young age, and we became citizens at 17, which was very convenient because then I could go to college. So I attended and graduated the University of Illinois at Chicago. After I graduated, I took a gap year where I worked and did research at the Illinois Eye and Ear Infirmary. After this time with ophthalmology, and that break, I was accepted to MCPHS University, and I completed my optometry degree there. After completing optometry school, I was accepted to Bronx Care Health System for their primary eye care and ocular disease residency in affiliation with SUNY, and graduated this June. After completing the residency, as Dr. Harewood had mentioned, I accepted a position at Bronx Care, and I'm currently faculty and continue to take care of the patients in the South and Central Bronx. This brings us to our first section to go over the common definitions that we'll be touching on throughout this presentation. We figured it would be a good preface to the presentation to go over the definition of access to care and several other terms. Access to care, as defined by the World Health Organization, is the continuing and organized supply of care that is geographically, financially, culturally, and functionally within easy reach of the whole community.
So we go through these definitions so that we can ground ourselves in the work that we're about to do tonight. And also you can understand the myriad of the spectrum of what access means. Other definitions that we'll be seeing during the presentation include health professional shortage area. And these are areas that have shortages of primary medical care, dental or mental health providers that might be geographic, population, or facility oriented. Then we have medically underserved areas. These are designated areas that have too few primary care providers, high infant mortality, high poverty, or a high elderly population. I get these definitions from this website that I've listed below. And if you want to hear more and know more about those definitions, we'll definitely have that as a resource for you. Moving on to our next slide, we have medically underserved populations. And these are specific groups that live within an area where there's limited access to primary health services. as per the definitions, that includes homeless, those with low income, Native American or Alaska Natives, Medicaid eligible, migrant farmers, and certain racial and ethnic minorities. Now, this is the specific definition in terms of these groups who are known to be in underserved areas, but I would actually add a couple other populations as well, including those who are in the transgender population, as well as service workers. Moving on to our next set of definitions, we have underserved populations. These are consumers with limited access to healthcare services. And then finally, vulnerable populations. And these are consumers who have additional barriers to accessing care. Now, it's possible that you can live in an area that is well served, where you have access to care, but you are a vulnerable population. And I would give examples of that being those who are elderly, those who have identified physical disabilities, those with cognitive disabilities, residents of assisted living or nursing home facilities, and undocumented workers would also fit within this designation.
All right, that brings us to our first poll. We just wanted to ask, I think the student is in charge of setting everything up and it should pop up, but what is your current practice modality?
Okay, I'm sure we can give those results after. Mm-hmm. And that just helps to let us know how to frame some of the information that we're giving you tonight based on where you practice and how you practice. Okay, so mostly private practice, some in corporate, hospital-based, academic, and other. So this information is applicable to all areas, specifically private practice as well. So, I've spent most of my career working in medically underserved areas and areas with vulnerable populations, and medically underserved, as I said, for the most part. Now, there are many benefits to working with this population. It's incredibly rewarding working with these patients. I don't have any data in particular, but I will say patients who I've worked with have been particularly appreciative of their care. It also allows for often a fuller scope of practice. And sometimes that's because you may be working in an area where you may not have access to other providers. So you may be doing most of the primary eye care and practicing at the highest level. Other benefits that you can sometimes get include loan repayment. There's certain areas, if you work there, you can actually get part of your student loans paid. I know there's definitely areas, if you move to them, there's benefits or extra added on your salary for working there. For example, I can tell you I had a colleague who was at optometry school with me who moved to Alaska and was able to get a northern allowance for that. And there's salary bonuses and a number of other reasons why it's great to work in these areas. So while it is great to work in these areas, just like there's two sides to every coin, there are some challenges as well. Often there's a high disease burden. I mean, you'll have patients who may have many different, comorbidities in the same patient. Sometimes it can be a very high volume practice. Sometimes you're under-resourced. When I started working at SUNY, I was amazed at the level of resources that I had access to. And finally, it's a culturally complex teaching, learning, and working environment. And by that, I mean, there's many different people, many different language a lot of the times. Sometimes your patients present to you not just with their eye care problems, but many other problems that affect their vision and their vision care. And you need to manage those things in order to provide proper and complete care. So that can be challenging sometimes.
Finally, let's define social determinants of health and how they relate to our patients' access of care. As defined by the Healthy People 2020 initiative, social determinants of health are those conditions in which people are born, live, learn, work, and play that affect a wide range of health, functioning, and quality of life outcomes and risks. These include a patient's innate individual traits, their individual behavior, social, family, and community networks, living and working conditions, and finally, broad social, economic, cultural, health, and environmental conditions. When we think about the health of our patients that come in to see us, of course, we're more focused on those innate individual traits, including like their age, race, medical history, social history, when we synthesize our thoughts on their presentation and possible treatment in conditions just such as glaucoma or retinal pathology or optic nerve disease. However, when we consider their health as a whole, we need to consider the other layers, including broad social, economic, environmental conditions that may affect how their treatment may be accepted after they've left our exam room. These particular traits are known as social determinants of health, and they've been studied to have a direct impact. As they inherently stratify individuals, groups, and populations, which Dr. Hare will discuss, you can see economic disadvantage, race, ethnicity, religion, gender, sexual orientation, and disability all play a role. In a cross-sectional study that was nationally representative, Zhang et al. Used a survey from the National Health and Nutrition Examination and National Health Interview Survey to synthesize information regarding vision health disparities in the US. The main outcome measures included the prevalence of eye disease, including macular degeneration, diabetes, cataracts, or effects of glaucoma, and the use of eye care services in those patients who were self-reported to have some degree of visual impairment, including despite correction with contact lens and glasses. We'll focus a little bit more on the latter, and specifically in the cases of race, ethnicity, education, and economic status. Looking firstly at ethnicity, non-Hispanic whites, more than 50% of these individuals reported presenting to yearly or as needed eye examinations in comparison to their non-Hispanic or non-Hispanic Black or Hispanic counterparts. In light of education, these individuals with less than a high school equivalent education in comparison with those who had greater presented less to yearly eye visits. And then finally, looking at the economic status of our patients or the participants in this survey, they were stratified by their PIR or poverty income ratio. The PIR is an index of total income assessed in relation to the federal poverty threshold that vary by family size and composition. So a PIR ratio of 1 is defined at the official federal poverty threshold level. And as you can see, there's a direct correlation between the patient's income level and their ability to ascertain eye care.
So as Dr. Tadapoli spoke about, social determinants of health are the conditions in which people are born, live, learn, work, and play that affect a wide range of health, functioning, and quality of life outcomes. And we can split those social determinants of health into many different ways. The first way is to talk about the individual versus the population aspects. So individual social determinants are person by person: gender, race and ethnicity, socioeconomic status, social class, quality of housing, language use, disability status. These are things that are inherent or that affect a single person and that can affect health. So as we move to an example of this in our next slide, this statistical graph came from the CDC, and it shows you life expectancy at birth by race and sex. So if we see here, the black line at the top is white female identifying people. The red line at the bottom is Black male identifying. As you can see, at birth, the life expectancy is significantly lower for Black males than it is for white females. Now, that is not because there's any genetic predisposition to dying early. That's more because the factors that are affecting health outside of just the person's body, and that's an individual social determinant of health. The next section that we speak about are social determinants of health on a population level. And these are more societal determinants. These are macro factors. And in order to affect change in these different determinants, you would have to make policy and structural changes. This includes poverty rate, educational opportunity, affordable housing, access to healthy foods. For a long time, we were discussing food insecurity. People are now talking about nutrition insecurity because sometimes you have access to food, but it's not good food. You're also talking about neighborhood housing conditions, healthcare services, and these many other factors that we're talking about here. In terms of an example of this, if we look at this chart, again, from the same website, from the CDC, what it shows you is cardiovascular disease mortality as it correlates to poverty, unemployment, and uninsurance rate. Uninsurance just means people don't have insurance. If you look at the far left, you can see with all races that the mortality rate that you have from cardiovascular disease is correlated with poverty. So the poorer you are, the more likely you are to die of your cardiovascular disease. There's also associations with unemployment and uninsurance, but not quite as strong. Once you pull out and look at the mortality rate based on different races, you can tell that the associations are much stronger. And again, as I said before, it's not as though these different races have any genetic predisposition as a whole to having cardiovascular disease or dying of this disease. It's more that the social, economic, and neighborhood and many other factors that I said in terms of determinants of health have an effect on their ability to have proper care.
All right. As I mentioned before, when I was talking about Healthy 2020 as the example for the definition for social determinants of health, in December 2010, the Department of Health and Human Services launched Healthy 2020, and it had 4 overarching goals: to attain high quality, longer lives free of preventable disease, achieve health equity, create social and physical environments that promoted good health for all, and promote quality of life. One of the tenets of the Healthy People 2020 was educating and integrating the social determinants of health into healthcare practice and management, which I'll go over shortly. First, they mentioned the neighborhood and built environment, how that may play an aspect. Availability of resources that support health within the environment is kind of what they were touching on, including, as Dr. Harewood had mentioned, access to foods that support healthy eating patterns, quality of housing, crime and violence, and environmental conditions. Looking at education, we're thinking more about quality, access, and promotion of education, including high school graduation, enrollment in higher education, language, literacy, and early childhood education and development. If you think about what you're surrounded by or what influences you had growing up and where we were able to, continue on with our education, that's kind of what I'm meaning when I say promotion of education. Economic stability, this was measured by poverty, employment, food insecurity, and housing instability. And then social and community context is similar to the way the environment works, but it's more of a social context, and similar to what I mentioned earlier about our relationship to education and what we grew up around. So social cohesion, civic participation, discrimination, and incarceration all played a role. And then finally, where we kind of fit into the puzzle, health and healthcare, a patient's access to healthcare, their access to primary care, and finally health literacy. So a little bit to go into detail here. When we're talking about access to healthcare, this is the timely use of personal health services to achieve the best possible outcomes. I'm going to outline a couple of aspects here, but if you consider each to be in a spectrum, we can see that they often overlap, but also at any point can limit that availability. So if you see here, if a patient does not have access to transportation, can't get to their exam, that's a limiting factor. If they get there and the resources aren't available for them in terms of exam room or the accommodations that they need. And then finally, insurance coverage. In most health systems that are not designed to address these specific barriers, the lack of one of these criteria impedes care completely. So looking at access to primary care, not just healthcare itself, this is the provision of integrated accessible healthcare services by a primary care physician. In a setting where primary care is available, we can have a more comprehensive exam and the doctor can address a large number of healthcare needs. They can develop sustained relationships, which can come from seeing the same provider consistently. And then this can provide care in the context of family and community, and they can develop trust between the patients and the provider and possibly their family members. Looking at health literacy, this is the degree to which individuals have the capacity to obtain, process, and understand basic health information needed to make appropriate healthcare decisions. This enables the patient and increases their capacity to take responsibility for their health. It facilitates communication between the provider and patient. And finally, it relates the healthcare organization interventions to promote health literacy. And we'll talk about that later on during the presentation. When we're talking about communication itself, we can see how that directly applies to our patients as it improves adherence to treatment, compliance with follow-up, and as we know, prevents or decreases hospitalization and utilization of emergency services. When you think about eye care, you think about how important it is in the management of diabetics or diabetic retinopathy. But even as you consider it outside of the exam room, and as my Pasco residents can probably attest to, the utilization of emergency services if a patient has a chronic retinal or optic nerve pathology or other anterior segment problems like corneal ulcers, or the education behind contact lens wear that prevents them from coming back to the ER with acute issues. And finally, proper education for the use of their medication that prevents rebound inflammation in cases when patients discontinue medication. This brings us to the last two concepts in relation to the attainment of health, which also have a basis in the fields of ethics and human rights, health disparity, and health equity. Prior to Healthy People 2020, as discussed in the article that I've listed there by Paula Braveman, there was no explicit definition of disparity as it related to health, but rather this ambiguous differences in health. With the focus placed on social determinants of health, the Healthy People 2020 was able to relate this as to an individual's ability to achieve health. And those that have social, economic, or environmental disadvantages, or who suffer from systemic discrimination or exclusion, are seen to have higher burden of disease, premature and or excessive mortality, poor health-related quality of life, and impaired daily functioning. So the attainment of health equity is the principle underlying the commitment to reduce these health disparities and ultimately eliminate them in the determinants and including dedication to the attainment of highest levels of health for all people is directly related to health equity, and we can use disparities as a metric, evidence, and obligation. A metric allows us to truly understand the differences between health outcomes between our patients, evidence of improving outcomes or conditions and care for our patients, and finally as an obligation as we ensure the highest quality of care for every patient we come across.
So really, if we can summarize the first portion of what we talked about, we're saying how you live really determines your health. A lot of health is not necessarily in the exam room. It's estimated that only 20% of the time, what we do in the exam room only accounts for 20% of how healthy we are. It's really what we do outside of the exam room and what we're exposed to that determines how well we live and how healthy that we are. So we've gone through all of these different things and spoken about the social determinants. And so why is that specifically important to us as optometrists? So first things first, optometry is a vital part of the comprehensive healthcare team. As you know, optometrists provide 85% of the primary eye care in this country. It's a lot of eye care. So in terms of when we actually see these patients, there are some patients where we are the entry point to systemic care for them. So there are patients who may come in to get their glasses or contact lenses who don't interface with their primary care provider as often. there are 276 different diseases that can have ocular manifestations. That means as primary eye care providers, we can sometimes see those things concurrently or even before they're seen by the primary care provider. So it gives us a very important role within the healthcare system. Next, as an optometrist, we all know that we provide a very collaborative mode of care. We work with other ophthalmologists, we work with dermatologists, primary care doctors, allergists, all of the above, in order to care for our patients, because often there are systemic reasons why they're having visual issues. So it makes sense that we're part of this comprehensive team. It's also important to note that visual outcomes directly are related to your quality of life. If you ask people when they get older what they're most afraid of losing, it's almost always going to be their vision and their memory. So it places us at a very important part of the healthcare system. It's well known that vision is associated with good cognitive function. There's a number of times, I can't tell you the number of times, that I've had patients come in from nursing homes. I see many nursing home patients, and maybe their aide or the person who's with them will say, do we really think there's going to be any benefit to taking the cataract out or treating this or treating that? And I'll say, there will be a benefit. There's evidence to show that it increases your cognitive function, increases your quality of life. So that places us at a very important part of the healthcare system. Finally, because our scope of practice allows for some medical management of eye disease and care, we have a very important role with this. And with that very important role and very important responsibility means we need to take care of the social determinants of health in order to completely care for our patients. So although in optometry school, residency, and all of the above, we learn all the different techniques in order to take care of the patient, we don't always know what actually influences a patient to come to see us. And Alexander et al. Did a study to look at what influences people's access or trying to receive preventative care. It's a qualitative research study that used focus groups in, I think it was Miami, Chicago, and San Francisco. And the hope was to help health educators and eye care providers refine educational materials to help communicate the importance of having regular screenings, even if you don't necessarily think you have any eye problems. So in terms of the actual study, they wanted to know people's attitudes about their eyesight and about their vision. So what they found is that people highly valued their eyesight, and they thought it was very important, it was vital and indispensable to them living on a day-to-day basis. However, they voiced they usually took it for granted. And many people in the study said that, they didn't think they needed to have an eye exam, and they did not link eye status to health status. Many thought routine eye care is not necessary and not important if they felt that they could see well. The next section tried to examine people's knowledge of eye health. And it found that, the knowledge of eye health was quite poor. People knew that a DFE was important, but they couldn't necessarily specify different eye diseases and conditions. They said they knew that diseases and accidents could potentially cause people to lose their vision, but they weren't really able to be aware of conditions like cataracts, diabetic retinopathy, and other eye diseases that we would commonly assume that people would know. Regarding eye examinations in general, they cited that fear and denial were barriers. So people were worried that if they came into their examination, they were going to get bad news, like they had glaucoma or bleeding in the back of the eye. And that was a reason why they would not seek care. And when did they access care or try to find out about their eye care? It was more if they had some sort of symptom and they wanted to find out about it. And when information was sought, it was also potentially to help a family member or a loved one. But still the level of knowledge was low. One statistic that I found very surprising and fascinating is that only 6% of adults reported that they had gotten eye health information from their primary eye care provider in the past year. There was definitely a time when you went to your PCP that they would put the eye chart up and have you read it and have some assessment of your vision. But the fact that 36% said they did not get that information from their PCP means maybe eyes are not being examined in the same way. Perhaps that type of eye health information and the importance of eye health need to better be disseminated to primary care providers. I would say, from experience, PCPs will definitely recommend an eye examination for their diabetic patients and often for their hypertensive patients, particularly in the hospital-based setting. However, for the patients who don't have those issues, perhaps that's not getting through the importance of an eye examination. In terms of communicating and sharing information, moving forward from that, primary eye care providers were often not as well educated regarding eye conditions. And as I said before, there's reduction in vision screenings or eye examinations at their PCP. So what this is basically showing is that there's a need for greater health literacy. Perhaps there's an opportunity when it comes to primary care providers as a way to help people know how important it is to get preventative eye care. And, disseminating that information from your primary care doctor, since people really trust their primary care doctor, may help facilitate, better beliefs and attitudes towards eye care and knowing how important it is in terms of your health.
Looking at what systems have been put in place or have been studied before regarding health promotion, we look at the landmark Ottawa Charter for Health Promotion of 1986. This is considered the gold standard for the health promotion framework, as it defined health as a positive concept, emphasizing social and personal resources as well as physical capabilities. This is different than in the past, where most health promotion frameworks were focused on correcting any failures of the system. And so when we look here, they advise 3 strategies for health promotions, including advocacy, mediating, and enabling, and then 5 action areas to apply these strategies, including building healthy public policy, creating supportive environments, strengthening community action, developing personal skills, and reorienting health services. As it relates to eye care, Hubley et al. Proposed a framework in their article, Eye Health Promotion and Prevention of Blindness in Developing Countries. I understand this was for developing countries, and you'll see, aspects that we might not think about day to day, but it does allow for more ocular health education. And he noted that ensuring adoption of eye health promoting behaviors and increasing uptake in eye care services was very important. They also found that education was fulfilled when underlying influences on behavior were addressed and appropriate methods, target groups, and settings are selected. So looking at the strategies that we touched on before, they were able to apply this directly to actualizing care in developing countries, including advocacy, mediating, and enabling. Specifically looking at advocacy, we can think about these in different orders of intervention. Like we talked about individual, group, or population levels for the social determinants of health. You can also see how interventions can be, in this case, in policies or changes in legislation to promote eye health, including the support for expansion of eye health services, economic support to increase affordability, provision of water, housing, and land legislation, safety legislation, and food policy or fortification. Second, looking at mediating, this is more at the individual, family, or community level, where there was education about eye health promoting behaviors, uptake of services, support for mass treatment, promotion of awareness, knowledge, decision-making, beliefs, and attitudes. And then finally, enabling. So this is more directed at the systems providing the care itself. So improvement in quantity or quality of services, services of eye care, patient education and community outreach, which we'll touch on later, supplies of drugs, water, sanitation, and vector control, and then testing, screening, and provision of spectacles. As we've discussed, access to care involves those dimensions which describe the potential and actual entry of a given population group into a healthcare delivery system. So what healthcare systems, what systems are in place to promote access to care?
So the first thing that everybody thinks of when we think about access, we think about finances. And if we think at what in the last 20 years improved access to care financially in this country, it would definitely be the Affordable Care Act, AKA Obamacare, in '08. And I can tell you, I've had many patients who have said, I didn't have healthcare until I was able to afford healthcare through one of these marketplace systems. So this made healthcare more affordable, or health insurance more affordable to more people. This law provides consumers with subsidies or premium tax credits that lower costs for households with incomes between 100% and 400% of the federal poverty level. And that changes, but you can look that up, what the poverty level is. It also proposed the expansion of the Medicaid program to cover adults with income below 138% of the federal poverty level. Not all states have expanded their Medicaid programs, but it recommended that. It provided, lower income individuals care, obviously, through the parameters there. It also allowed young adults to remain as dependents. So 26 and under, you were able to remain as a dependent. And what that meant is that you would have access to your parents' health insurance. Finally, it helps to support innovative medical care delivery systems that were supposed to lower the cost of healthcare. And if we think about some of those innovations we may have used at the height of quarantine periods in the pandemic, like telemedicine and other ways that we can access care more affordably and more equitably.
Now that there has been expanded coverage, theoretically, the limitations to care were addressed, right? And that's not always the case. In the article, Massachusetts Health Reform and Disparities in Coverage, Access, and Health Status, Zhu et al. Actually documented that there was a persistent limitation in care despite the expansion of Medicare under the ACA. 40% of the surveyed individuals reported some deficiency in their care, even though their insurance coverage had expanded, and that financial barrier was no longer an issue. Massachusetts was considered the model for medical coverage under the ACA in the United States, and as a health reform has achieved near universal coverage. When asked about the persistent limitations, surveyed individuals noted barriers related to their provider or their health status as leading obstacles.
In terms of access to care, there's evidence to suggest that even when people have the same level of insurance and same access financially, they don't receive the same coverage. So Wilson et al. Noted that even among Medicare recipients, Black Americans were only 60% as likely as white Americans to undergo cataract surgery. In an observational study, Schneider et al. Noted that in Black patients, they were perceived to receive a poor level and poor quality of care. In the large-scale Los Angeles Latino Eye Study, which some of us may be familiar with because a lot of different data came out of that study, the data suggested that those who were on publicly funded insurance had similar rates of uncorrected eye disease as those who had no insurance. So you see that there's some sort of gap. There's somewhere that's missing. So it's not just about coverage. There are many other factors that, we as eye care providers can help to fill that gap or help to do things to help fill those gaps for our patients. When we think about access to care, there are personal issues that stop you from accessing care. Family responsibilities, work responsibilities, I get off work, maybe I work at night, I work in the day. Not everybody actually has, time off for sick leave, or not everybody has holiday. People who work on an hourly wage may not be able to access a doctor who only works from 9 to 5. There's also childcare availability, which is huge for people. That's why sometimes, in our exam rooms, you may have one person coming for an exam, 5 people in the room. Potentially, it could be that they were not able to get somebody who was able to take care of their children. There are also provider issues, and this is something that we can control, and I will get into it in the latter half of the presentation in terms of how we can mitigate this. But language barriers are huge. There's so much evidence specifically in the hospital setting where there are a lot of medical errors that are related to a language barrier. People could not understand and were not taking the right medications or not following the right recommendations. There's cultural or religious lack of understanding. You know, if you walk into an exam room and you do something that may offend somebody, you may not know you're doing it, but immediately that sets up a barrier that you have to overcome for that patient to trust you and for you to be able to deliver the type of recommendations and care that you want. Also, it's not just the provider that's important, it's the entire office environment. It's walking in and being greeted by the front desk staff in a way that makes you feel comfortable, welcomed, and like you belong. Finally, there are system-wide issues like insurance coverage that we spoke with, financial barriers, but also the availability of appointments. I can say in many places that I've worked before, I may not have an appointment for the next 6 months. You know, and for somebody who's really trying to get in or they have an issue, that's a problem. But if you work in a health professional shortage area, those are things that you're going to face every single day. Provider availability, appointment timing, as I said before, and familiarity with location.
As you can tell throughout this presentation, I really do like definitions and kind of ways to frame the conversation that we're having into a couple of terms or framework. So looking at Penchansky and Thomas's article, Dimension of Access, there are limitations that we've introduced that aren't associated with finances. And so a more comprehensive understanding was necessary when considering legislative or system-wide change. They put forth this multidimensional definition of access, which was central to the attainment of health outcomes. It included affordability, accommodation, availability, accessibility, and acceptability. And we'll go over them in detail and introduce practical approaches to help out patients. Finally, as we discussed earlier, there are many outside of affordability that our patients are burdened by, as listed in non-financial barriers and access to care for US adults. We'll take a chance to introduce and review each of these limitations and how we as optometrists can use practical approaches to affect change. But for right now, let's just take a really quick break before we delve into the rest.
So before we start the second portion, let's take maybe about 5 minutes or so to digest the information. Feel free to, get a drink, non-alcoholic, of course, and turn off your cameras if you'd like for the next 5 minutes. Feel free to ask us any questions as well. But just before we delve into the other part or the second portion of our presentation, which will really be introducing solutions. About 5 minutes, 5-10 minutes. Okay, so we'll give everybody just a few more seconds to come back on. Just a few housekeeping things. I saw in the Q&A that someone was having a hard time with the sound. If you are having a hard time with the sound, can you put something in the chat? I just want to make sure that we're coming through well. So if somebody can just confirm or not confirm better, you can hear us properly. Okay, great. So that's one. And two, somebody asked whether or not I could see what that icon was. It was an icon that I put up when I spoke about working in Staten Island. It looked a little bit like this. If you're a hip hop fan, which I am, very much so, you know that's the sign of the Wu-Tang Clan, and they are from Staten Island. It's completely non-I related, but that's the sign that I was putting up for Staten Island. So to answer that. Okay, Matthew Harper's got that. Great. So shall we get back started?
Yeah.
Okay. Hopefully you're back.
There we go. All right.
So now that we've given you all the different barriers to think about and to work through and think about how difficult it is and how many things that need to be done, we are actually going to provide you with some very tangible solutions that you can use to get through some of these barriers for your patients. So first things first, we'll talk about affordability. Now, as I said, the ACA did open up to make things much more affordable for a lot of different people. But there are other people who don't necessarily qualify for Obamacare or who are not able to access it because they may be undocumented or for any other reasons. So how do we take care of those patients? Now, common complaints, and I definitely have heard this on a regular basis. My insurance isn't covering my drops. These over-the-counter drops cost way too much. My copay is too high and I simply cannot afford it. So we ask you, how often have you heard those complaints? Let's just say in the last month. And we'll give you a minute or so to vote.
Okay, perfect. This up. We'll just wait a few more seconds to get about 50% participation. All right. And share.
Okay, 0 to 5 times. Still a lot of times for our patients. So we still have a lot to do when it comes to that. So ways that we can help patients who are having trouble or unable to access medications or care include many of the following. So there are eye insurance options. There are options to reduce prescription costs. There are patient assistance programs. There's access and easier access now to PAs or prior authorizations. There are testing kits that can help those of our patients who have genetic diseases or that we suspect have hereditary retinal disease. And there are some options for more specialty eye care where you can get coverage. The first thing to mention is, as we said, the statewide exchanges. If people have the ability to access this care, you want to try to recommend that they apply for it. If a patient is a citizen of the US or a legal resident of the US, they are able to access these exchanges, which are associated with Obamacare. And these plans allow you to get more affordable care. So even if you're not at the poverty level, you're able to get more affordable options. Now, they may not be great in the sense that they may not cover everything that you want them to cover. As somebody mentioned, you're definitely going to have to prescribe generics in a lot of these plans. However, they are going to get somebody access who may or may not have had access before. Now, associated with these plans, there's a number of stipulations so that these insurance companies are not gouging patients and whatnot. So it allows people to have more equitable access to care. In addition, there are children's programs, and I'm going to speak specifically about New York because I think most of us are practicing in New York. We have the CHIP program in New York State. This is a specific low-cost program for children and for pregnant women who are American citizens or legal residents of the US. And using the website below, and I think I also referenced the website from the exchange programs from New York. That's also on that slide if you want to refer to it at any point. And also we will have a resource guide for you at the end of the presentation. Anyway, moving forward, there are children's programs that kids can be covered under that will allow them to access not only eye care, but healthcare. And there are also patient navigators, enrollers, and other staff who can assist them in accessing this care if they're having trouble actually navigating just signing up for the system.
Practically, when we're looking at reducing prescription costs, there are ways to work with pharmacies. So some pharmacies make generic medication available at reduced costs, including, as listed here, common systemic medications as well as some ophthalmic. These are available for patients for usually a yearly fee. When I was looking, usually for individuals, it's about $20, and for a family, it can be as low as $35 per year. And it can help those who don't have insurance that covers all their medications or have very high copays. Benefits usually include up to 80% cash price reduction on medications, 5 to 20% on vaccinations, and 10% bonuses on other products at the pharmacy. So as you can see here, this is the target example. There is some IOP lowering medication as well as topical antibiotics that are listed here. And it depends on the duration of use as well. So it could be $4 for a $30-day quantity or $10 for a 90-day supply. Walgreens is also another pharmacy who makes this generic medication available. There's some systemic medication there. And then here again, antibiotics and IOP lowering medication available at 30-day or 90-day quantities, depending. Walmart and Sam's Club also have a pharmacy savings program if that's of interest. Medication, oh, sorry, this is Dr. Harewood, can you take it away? Sorry about that.
That's fine. It's also important to note, and I think most of us will already know, if you prescribe a 90-day supply, it's actually going to be less expensive in the long run than prescribing a 30-day supply for your patients. So consider doing that if patients don't have good access to care. Now, medication coupons, the GoodRx, Blink Health, and WeRx, I use flagrantly when I was in Staten Island. The reason being, what you can do, for example, if you go to the GoodRx, if you just click for the GoodRx to come up, if you go to the GoodRx website, you can type in what medication that you want. Let's just say it's Timolol. And what will come up is the price of that medication, cash price, non-insurance price, at many different pharmacies. That could be Walgreens, Duane Reade, all of the above. So you can actually compare to see where the medication is the least expensive. And once you select the one that you want your patient to go to, you can print out a coupon that you can give to the patient before they leave so that they can get access to a medication at that cost. I've used it many times and it actually works. The coupon works. And sometimes, it can be even cheaper than a copay. I wouldn't necessarily recommend that people do this instead of going through your insurance, but it's very important to note that sometimes it's very inexpensive. Now, other websites like Blink Health and WeRx also offer that availability. It's important to note that the GoodRx also offers telehealth exams. So for people who are uninsured or underinsured, there are a number of different services that they can get through the GoodRx website. You can pay either a $19 fee or a $49 fee for these programs. And it's almost like signing up somewhat for insurance. And you can access a healthcare provider via the web, online, and they can help refill certain prescriptions. They can help give certain prescriptions, provide mental health care. And this is for people who do not have insurance at a much reduced price. So if you have patients who are having trouble accessing the system or accessing general primary care, any of these options are excellent. And we will have a handout with these options on there as well.
So aside from the pharmacy itself and then those 3 websites that Dr. Harewood had mentioned, there's also a way you can work with the pharmaceutical company. So for example, Pfizer, who's a producer of Xalatan, has Pfizer RX Pathways, which allows you to sign up a patient for patient assistance. And this makes that medication available to them at much lower cost, given that they, fulfill that some of the qualifications that are listed, including, and depending on where you might practice, commonly being below the poverty level, not having either access to insurance or being uninsured. Aside from Pfizer, there's also Merck Helps, which produces Cosopt, Timoptic, and Trusopt through their 2 Merck Helps websites. Novartis, responsible for Azopt, Allergan, so Alphagan P, Lumigan are 2 examples, and Torlac listed there. And then finally, Xiidra. So this also has, I think it's more of a card that's associated with using this into chronic medication that you'll be refilling. All of these, as Dr. Harewood had mentioned, are going to be available on that resource sheet.
If I can just add something, often when you sign the patient up for that program, it means that they're chronically in that program, meaning that they can have access to their glaucoma medications on a consistent basis. I'm not sure exactly, maybe Dr. Tadapuli, whether or not they need to renew it on a yearly basis, but I know it's something that you apply for and you have access to. And it's not like you to apply for it with every bottle.
Yeah, so I don't know for sure, but I know for Xiidra, that's something that you would do depending on a yearly basis. And so that might be something that you might have to intervene in at a regular interval, but it's nice when you have these follow-ups for patients that are taking glaucoma medication, for example. That's something that you can quickly address because they have that portal that you've already created for them.
Additional to address, sorry, Dr.
Yeah.
A comment in the chat regarding Xiidra. I agree. Xiidra, I have found I've had some trouble in terms of trying to get people covered under Xiidra when it comes to these programs. But I recently learned that even for people with insurance, sometimes Xiidra is less expensive if you just give them the coupon and tell them not to bother with any of the insurance. It's terrible to think about, but sometimes it's just cheaper that way. So that's another option. I would try it that way if you're having trouble.
Yeah, definitely good to know. Good to know. So like we mentioned earlier about the difficulty with the insurance, Xiidra is one that may require prior authorization, which is a process that us as healthcare providers have to do to obtain advance approval. So this could be for medical services, but more often in our case for prescription medication. We all kind of know how difficult it is. In 2020, actually, the American Medical Association surveyed providers who routinely had to submit prior authorizations for medications and found these results. So looking at care delays associated with prior authorizations, almost 91% reported care delays often. Looking at abandoned treatment associated with PA, I know we mentioned Xiidra, someone had mentioned they had given up because it was difficult. Over 74% noted that they often had to choose alternative treatment or abandon the course of treatment that was first recommended. And then finally, impacts of PA on clinical outcomes. So 90% of practitioners reported somewhat or significant negative impacts on the prior authorization process and approval. Looking at reform, the PA proposed rules was brought out in August of 2020 by the National Committee on Vital and Health Statistics Subcommittee. And these proposed rules that may be applied to this online process or process in general to make these medications available to our patients. And all were co-signed by the American Medical Association, the American Hospital Association, America's Health Insurance Plans, the Pharmacists Association, Blue Cross Blue Shield, and the Medical Group Management Association. So I mentioned earlier that it was proposed in August of 2020 and it was heard in Congress, but there's only been follow-up correspondence, which was published in October of 2020 with no action yet. The American Medical Association did offer, prior authorization tips, and this will be available, looking at kind of what you can do to make the process a little bit easier, whether you're faxing or calling it in. But of course, as a final word, it's important just to call the pharmacy sometimes or call the insurance providers if you can. There are similar to what Dr. Harewood had mentioned in terms of medication resources, online resources for prior authorizations, including ProRx, Cover My Meds, and Express Scripts, which are websites that you can use to help this process go along a little bit easier.
I will say I definitely use Cover My Meds, no particular reason, but I found it a little bit easier in terms of communicating with the pharmacy to get those prior authorizations through. In terms of affordability, a number of times we might suspect some sort of hereditary retinal disease for our patient. And previously, testing genetically has been prohibitively expensive. Now we have things like My Retina Tracker, which is an open access genetic testing program for patients with inherited retinal degenerations. So what you do with this is, as a provider, you can go on their website. There's this Nucleus portal that they have, and you can order the testing kits. These testing kits are really just a saliva sample. So in your practice, you suspect somebody or they've been diagnosed with a hereditary retinal disease. You give a swab, or they take a swab of a buccal swab. You send that back to the company and they will do that genetic testing for free. It's fantastic. They will also provide genetic counseling after that testing, and that is also free of charge. And it's with My Retina Tracker with an associated philanthropic organization. I'm forgetting the name of the organization, but it allows for you to get genetic testing at very low to no cost. And that covers retinal diseases like achromatopsia, Best disease, cone dystrophy, cone rod dystrophy, fundus flavimaculatus, and all of those long names that we know are associated with genetic disease in the eye. In terms of in vitro testing, that's a similar service. To my knowledge, that is not completely without charge, but it is at a much reduced cost from what genetic testing would usually be. Finally, there are online resources that can help to aggregate the data from all of these genetic tests, and that can help to explain a little bit better what these tests mean. ClinVar and Omim, I don't know if I'm saying these correctly, but regardless, these are sites that aggregate these genes and genetic variations and disorders, so you can help to educate your patients a little bit more about their hereditary retinal disease. I can say that Bronx Care, the one that we used was Spark Therapeutics. And Spark Therapeutics, we would order through their website. And again, we would do a buccal swab. We'd send it back and we would get the genetic testing results relatively quickly. So this is something that you can do. I will say there are also certain industry and companies that are looking for people to do research on. And we'll get into that a little bit farther down into the presentation. And that can also make things affordable for your patients. Specialty eye care. I know in optometry, we're not supposed to say specialty, but I'm using it for now to explain the different types of eye care that you may want to refer your patients to. There's a common misconception that vision rehabilitation or VT or however we want to call it is not covered by any insurance. There are actually many insurance that will cover vision therapy. I can't say every insurance, but when in doubt, try when it comes to these insurances to see if they're covered. So when I checked into it, there were a number of different insurances that cover this for your patients. Contact lenses, there are definitely requirements for medically necessary lenses. As providers, I think when we hear about medically necessary lenses, we specifically think about people with keratoconus or other, diseases or disorders of the front of the eye, keratoglobus, that require a hard lens. There are also other parameters that allow you to qualify for medically necessary lenses. So for example, there's certain insurance companies that if you have greater than 8 diopters of ametropia, whether it's myopia or hyperopia, they will cover insurance, soft lenses for your patient. If you have more than 3 diopters of anisotropia, certain insurances will also cover lenses for your patients. So I would just be mindful of some of these insurance intricacies in order to get your patients covered for necessary care. Just today in the clinic, I had a patient who was about a -9, -3 with some oblique axis OU. And we were able to refer him to get medically necessary contact lenses because we showed improvement in his vision, potentially with lenses, and the fact that he could see much better with them. I will say, and one more click here, regardless of whether or not you think that it will be covered, always recommend the level of care that you think is appropriate for the patients. I think there are times where somewhere we're thinking, this patient may not have a lot of money. I don't want to necessarily recommend something that they cannot afford. But at the end of the day, let the patient decide what they can afford. Make the recommendation and then try to make some sort of accommodation to allow for the type of care that you want to give.
Moving forward, now that we've discussed affordability, we can talk a little bit about accommodation. Common complaints that you might hear from patients who have issues with accommodation. This is kind of the usability or functionality of a practice, or the organized way the practice runs. They have difficulty coping with vision changes, or there's not enough low vision resources available at that clinic. Ways that we can kind of work with patients or resources that are available to us include social work, the Commission for the Blind, and the Lighthouse Guild.
So get to know your social worker. Hopefully you have an affiliation with a social worker. I can say in terms of my own practice, it has been infinitely improved by having a relationship with the social worker. They can help with the psychosocial aspects of visual functioning and organizing outreach services. And they're really part of the holistic care practice. So things that they're able to do and help with include finding transportation options, helping to facilitate insurance coverage. And it's really an interprofessional partnership that is very useful. At SUNY, we do definitely use social work quite a bit. They're on the floor, the vision rehab floor, and they help to facilitate a lot of the low vision care and a lot of the vision rehabilitation services. Now, I will say in my mode of practice, for the most part, I've used them in terms of a disease-based practice. So in terms of education, in terms of referrals, advocacy for rehab services, worker school accommodations, finding housing arrangements, trying to deal with difficult domestic situations. I once had a patient who had a domestic violence situation where she could not get access to her insulin, and she needed to have somebody to facilitate her to be able to get out of the situation that she was in and into, somewhere where she'd be able to access all the services. The social work relationship that I had allowed me to help to facilitate that care. It can also help people with appointments for health and mental health services and other specialized services. So they're very an important part of the healthcare team. And as I said before, coordination of low vision care, vision rehab care, and insurance is extremely important. I would say just as you may have a relationship with a retinal specialist or a glaucoma specialist, corneal specialist, your LASIK doctor, if you have the ability, if you have the card for social work, whether that's at a local community health center or somewhere in your area, it's infinitely useful for the patients that you have who are unable to access the system because of other barriers to care that are non-financial. In terms of low vision, and definitely our low vision specialists are the ones who gave me a lot of this information, connections to supportive communities are just infinitely helpful and important in the low vision population, whether that be online or in person. And again, a lot of these connections can be facilitated through social work, But if you have knowledge of some of these, it's also useful. Assistive technology specialists help people use new technologies that can be used with the activities of daily living. Mobility trainers help people in order to move around, be able to do their daily living activities, even with their level of vision. And one program that I think is particularly interesting is the National Talking Book Program. So what that is the National Library Services will actually provide free reading material, talking books for people who have temporary or permanent low vision. And that can be accessed through the website. Again, that will be on the resource that we'll provide at the end of this presentation. And it will actually allow them to access hundreds, if not thousands of books and reading material that is, audio. And that it's provided either by free postal service or being sent for free to their house, or they can download it on whatever device that they want to use it on. So it's pretty amazing when you have trouble accessing so many different things, to be able to read a book and to be able to read books for free is really pretty amazing. So as long as you're an American citizen and you have access to mail or to a service that allows you to download these books, you can get them for free.
As we were talking about low vision, of course, we know about the Commission for the Blind, and their mission, at least in New York State Commission, is to enhance employability, maximize independence, and assist in the development of those capacities and strengths for those patients who are legally blind. As Dr. Harewood had mentioned, that collaboration with other providers of social work or occupational therapy in some cases may provide that added benefit to low vision patients. Of course, we know how to apply to the Commission for the Blind, but it will be listed in the resource list. Some resources that are available at the Commission for the Blind are vocational rehabilitation programs, business enterprise programs, children's programs for after school or during the summer, transition programs, summer recreation programs, as I mentioned earlier, and then independent living. Another resource that's available on the website is the equipment loan. So this is a loan fund for the disabled, and it helps you purchase equipment that can improve, the daily quality of life. Equipment that is covered includes wheelchairs, as well as maybe ramps, communication devices. We think about the low vision or near reading devices that we use, prosthetic devices, or those that help, allow blind or visually impaired patients read material. This is available online, and you could see here, you can sign up for your patient, listing their name, the diagnosis they may have, and how they'll use that proposed purchase. The Lighthouse Guild is also available for low vision rehabilitation services. This is the application as well. And they more are a comprehensive care center. So it gives the opportunity for those patients to be seen in a setting that is accessible to them for primary care, diabetes care and endocrinology, occupational therapy, physical therapy, optometry, of course, and then podiatry.
So it's also in-office accommodations. When you're a patient and you come into an eye exam room, or you come into a room and you're interfacing with the doctor, often having so much trouble fitting into the equipment can be similar to trying to fit into clothing that's too small for you. So you always want to try to do whatever you can to examine your patients as comfortably as possible. Handheld equipment is great, handheld slit lamps, eye cares, that type of thing. Trial frame refractions, even if you're not well versed in exactly how to do the classical trial frame refraction that we learned in school, putting a patient's prescription in a trial frame and just changing the lenses to try to get their prescription to their comfort is incredibly important. Another thing to note when you're thinking about people who may be mobility impaired or wheelchair patients, think about what they'll be doing. Ask them what they're going to be doing in terms of their visual needs. Sometimes their visual needs are a little bit closer. So you may want to put an ad in that's a little bit stronger so that they're able to access their environment in a way that's comfortable to them. As I said, accessible seating. Think about lighting. thinking about whether or not it's difficult for your patients to navigate into your exam room. Do you have narrow hallways, that type of thing? Whatever you can do in order to try to make your patient feel comfortable, they're really going to appreciate it. The other part that I really wanted to touch on is language translation services. I've been reading up quite a bit on access to care, and a huge thing is really inability to understand your patient and inability to understand recommendations for your provider. There's a lot of harm and a lot that happens when we're unable to do these things. The number one thing to do is really just to learn the language. If you're living in an area where there's a high Spanish-speaking population or Urdu-speaking population, knowing a few words is useful, at least in making a patient feel more comfortable, like you're trying. But in terms of getting to the nitty-gritty of explaining glaucoma, macular degeneration, diabetic retinopathy, really your language translation services are going to be most helpful to you. That can sometimes be in person. Sometimes some of our staff can help us with that. But it's actually best via telephone and video with a trained translator. The reason being, they're going to understand and know those medical terms and how to break down those medical terms in a way that's going to be understood by the patient. I'd also say when you are accessing language translation services, the more specific you can be, the better. So I remember having a very difficult time with a patient who spoke Arabic, and I had gotten an Arabic interpreter on the phone. So, that's all I need, right? I'm great. But he didn't just speak Arabic, he spoke Egyptian Arabic, and the language translation services had that. So by accessing that type of Arabic, I would have made it infinitely easier and much more efficient and shorter to get this patient their care. So if you have access to it, use it. A lot of the time you feel like it's going to take us longer. Most of the time, it actually takes us less time in order to see our patient efficiently and provide the level of explanation that they need to be seen.
When we look at availability, this kind of ties into kind of like accommodation and less like affordability. It's more like what resources are available to us. Looking at specific issues, so right services, right resources to meet the community that you're serving. Common complaints that you might hear is that you might need individualized medication or no access to specialized therapies. Resources and options that we'll go over here are research studies and 340B pharmacies.
So this is what I was touching upon previously when it comes to availability. A lot of the time there are research studies that we can enroll our patients in which may allow them to get access to care. However, there are many marginalized populations, vulnerable populations in particular, that have a fraught history when it comes to the medical research industry, and their skepticism is 100% warranted. We saw that very well from experience with COVID-19 and vaccine uptake. There's a lot of mistrust of the medical community. And why is that? I can give you many examples, but I've just chosen 3 to help explain why people may have a hard time with the medical care and trusting the medical healthcare system. So this is a picture of J. Marion Sims, and this is his statue, which was in Central Park, and it was just being removed. I think it was just removed a couple of years ago. So J. Marion Sims was a gynecologist, and he's commonly known as the father of modern gynecology, and he perfected many surgical techniques. However, these surgical techniques were perfected on enslaved Africans, and they were perfected on repeated surgical intervention without anesthesia on these patients. So this is something that is known, and people complained, and his statue was removed from Central Park because we don't want to celebrate that history. And that's one reason why there may be mistrust in vulnerable populations. The next example, people may be more familiar with, and that's Henrietta Lacks. Very good book and a very good movie came out. I think Oprah was associated with it, about this woman and her history. So as we know, Henrietta Lacks was a woman young woman who had cervical cancer, and this is in the 1950s. She was treated, actually, I believe it was at Johns Hopkins, and she was treated, and unfortunately, they were unable to save her, but they were able to harvest some of the cancer cells that unfortunately, made her lose her life. And those cells were the first immortal cell line for research. What that meant is these cells that don't really die. And so in terms of doing research studies, they're incredible. These cells, once discovered, were used in every single medical application that you can think of. And they were used, and her medical information was disseminated and told to people without, getting permission from her family, without necessarily going about things in a way that would acknowledge the fact that she had made such a contribution to science. It was to the point where medical researchers and doctors were contacting her family to find out genetic history and whatnot about her. And they didn't even know her cells were being used. And this is for quite some time. These cells were even used to make the COVID-19 vaccine. So it's a well-known story and a reason why people may have some mistrust of the medical system. By far and large, the most well-known reason why there may be some mistrust of the medical system by marginalized populations is the infamous Tuskegee syphilis study, which I think a lot of us know about, but maybe we don't know the specifics. So this was an observational study of about 400, poor and under-resourced Black men in the South who had late-stage syphilis. At the time when it started, there was no cure for this disease. And they were told that they were being treated for something called bad blood and that they were in this study being treated for this. But it was really an observational study to see the manifestations or how late-stage syphilis looked like on a person. Now, this study, they were only supposed to do it for 5 years. The study actually lasted for 40 years. And these men were not told that they had this disease. They were not told how to stop the transmission of this disease. And even when penicillin became available, they were not offered it. So even though people don't know exactly the different specifics that I'm telling you today, people are aware of these things in the medical research industry. So there needs to be a trust that is built back in terms of trusting that they're medical providers and that the medical system is going to do right by them. And I think we need to be cognizant of the fact that there's a real reason for people to be a little skeptical. So if you're recommending that a patient, enter into a particular research study, or you're making a recommendation and the patient may or may not be comfortable with it, know the history and try to build a relationship such that there's a trust and that they don't think that you're going to do these type of things. Obviously, now there's many different things that have been put into place. So hopefully these things don't happen. But the perception being there is the barrier that we need to overcome.
In light of, the history, there's been a lot of protections, like Dr. Harewood had mentioned, that are put into place. And the goal of clinical research now is to develop generalizable knowledge, improve human health, and increase understanding of human biology. It's important to consider ethical guidelines set in place to protect your patient, and these were implemented to correct the wrongs of prior human research endeavors. So the Nuremberg Code in 1947 was a direct response to the Nuremberg trials, the Declaration of Helsinki after medical research with human participants, the Belmont Report in response to the Tuskegee experiment, CIOMS, which is in collaboration with the World Health Organization, and then the US Common Rule in 1991, which was revised in 2018, and it outlines the basic provisions for review boards, informed consent, and assurances of compliances. The National Institute of Health outlined 5 key requirements for the validity of research in light of the past, including that they contribute social and clinical value, fair subject selection, favorable risk-benefit ratio, informed consent, respect for potential and enrolled subjects, and finally, scientific validity. Current studies and opportunities that are available online for us to see transparently include the NIH's Clinical Center, clinical trials to the United States National Library of Medicine. And then, of course, as it relates to optometry, those that are available at SUNY College of Optometry, the Clinical Vision and Research Center. As you mentioned earlier, availability, when we talk about a patient that comes in and says, I need specialized medication, I can't get it. Another way that this care was made more available was through the 340B pharmacy program. So in 1992, Congress passed Section 340B of the Public Health Service Act, and it's aptly named the 340B pharmacy program, which requires pharmaceutical companies to provide discounts on outpatient drugs to covered entities as a condition for participating in Medicaid. These covered entities include safety net hospitals, which are often teaching hospitals, children's hospitals, outpatient cancer clinics, Ryan White clinics, state AIDS, drug assistance programs, and other safety net providers. Applications for the money that is saved through these programs allow hospitals or these covered entities to provide drugs for free or discounted rates, implement funding into prevention-focused primary care clinics, mental health and substance abuse treatment, home infusion, nursing, transportation, and housing, but overall, healthier communities. So it's a way to give back from what the pharmacies are giving discounts on. Lastly, looking at accessibility here, we can see this is more of a reasonable proximity to the consumer in terms of time and distance is what it's addressing. Common complaints is it took too long to get to the doctor's office from home and work. This echoes what Dr. Harewood had mentioned earlier about personal issues, or it's too hard to get there. Again, one of those personal issues that we talked about in the beginning. Resources and options that we have are community outreach, going to the community itself, and then record release and referral, getting that specialized care by working with other providers. Inconvenience of follow-up, lack of understanding about the benefits of early intervention, family priorities, like we touched on earlier, concerns about cost, transportation issues, and lack of effective communication methods were all cited as issues with going to receive care. Optometry plays a role, like I mentioned earlier, with primary eye care providers, but if it's difficult to get that first eye exam, it might be difficult to then continue to follow with another provider as needed. So one of the studies that was put in place to compare current programs for community outreach was set in Philadelphia, and it looked at the outcomes of inner city outreach programs. They focused mainly on Give Kids Sight Day, which is a program set up so that there are eye examinations provided at no charge on Saturday. So that alleviates, scheduling conflicts. Interpreters are there available on site to assist with translation when needed. Children who fail the vision screening immediately have a refraction that day, and they're prescribed glasses at no cost. And then children whose vision can't be corrected optically, or who are considered, to have something else, other disease process going on, they have a full ophthalmic exam that day with a provider that's available. Additionally, as Dr. Harewood had mentioned, social work was available. So social work became immediately involved during Kids Sight Day because of other programs, including Eagle's iMobile program and Wheels on Wheels, which I'll talk about in a second. But they were able to assist all children who needed continuing care and resolve any issues that might prevent them from coming back to the clinic. So this significantly increased the proportion of children who returned to the clinic compared to the previous years. And from their study, in the 3 years that Gives Kids Sight Day had been going on, before the inclusion of a social worker, only about 5% returned for their follow-ups, versus after the addition, the follow-up return rate was about 60% of cases. So the Eagles iMobile program is another option in Philadelphia. The only issue is they needed an ophthalmology referral, which, as I mentioned before, you can have that social work kind of collaborate with you, but with Give Kids Sight Day, they were available on site. And then finally, for Wheels on Wheels, they needed the glasses after the fact. So they would come back for the glasses or go to an optical to get them made.
Another important element of accessibility is the ability to have access to your medical record. So as we know, as members of the comprehensive healthcare team, in order to get people the best holistic care, we need to make sure that communication with their providers or their primary care providers is there. So, outside of ophthalmology, optometry works the most directly, one would say, with primary care providers. So providing appropriate communication with the patient and to the referring provider helps with health outcomes. So that even means making sure that you send that diabetic report, making sure that if somebody directly refers someone to you, that you get back to them, whether or not that means by paper or picking up the phone. A lot of our EHR systems now will generate a report, but that report is critically important because where a lot of mistakes happen, particularly in those who are in under-resourced communities or vulnerable populations, is in the handoff. So the space in between providers. So providing other specialists that we work with the most complete information about our exams makes it very much easier for people to access and get whole person care. So acceptability is the last one that we will get into in terms of these healthcare barriers. And acceptability captures the extent to which the client is comfortable with the more immutable characteristics of the provider and vice versa. These characteristics include age, sex, social class, ethnicity of the provider and of the client, as well as the diagnosis and type of coverage of the client. And I think I have that definition up there as well. All right, so some things that people might say is, I didn't like that eye doctor. They used drops and I couldn't see. They didn't tell me that they were going to put these drops in. In essence, what we're talking about here is the patient-provider relationship. And there's tons of data to suggest and to show that this is critically important in people accessing care and people continuing care and adhering to our recommendations. And one of the main burdens that we see is not just with us, but also with staff who may work there, feeling uncomfortable, not feeling as though they're people who should be treated and all of those things. So one thing that people often talk about is cultural competence. And cultural competence means the ability to relate and to provide care in a way that respects other people's culture. In terms of people who do, diversity and inclusion, and even the general population, people are moving more from cultural competence to something called cultural humility. The reason being saying culturally, I'm culturally competent. It makes it sound like there's a way to finish in that you don't have to continuously keep learning in order to keep that competence. It's not something that we check and we're done. Cultural humility, as we say in this definition, it involves a level of self-awareness, of personal and cultural biases, as well as an awareness and sensitivity to the significant cultural issues of others. And it's an ongoing process where we're always trying to learn about others so we can best relate to them. So, in order to provide necessary services to people from different backgrounds, there actually has been legislation introduced to recommend that, certain types of training are necessary for our doctors and our healthcare providers. And that's because mistrust, as I said, of medical advances and medical mistrust, all those different things can delay care. And when patients don't feel like you understand them, they may not want to listen to you. So having that ability, that cultural awareness to talk to people is important. Just as important sometimes as knowing how to properly examine a patient, knowing how to talk to them and disseminate information is critically important to their care. So different things that we can do are really, cultural sensitivity training. There's some things that you can't learn in a book, but there's some things that you can learn by going through training. And that includes anti-racism training, anti-discrimination training, anti-bias training. Most recently, we had safe zone training at the college here. And what safe zone training is, and it's a free project that's available to everybody, It is a type of training that is supposed to instruct you on how best to respect and be sensitive to people in the LGBTQIA populations. And as I said, it's free training that's available online. And it gives you the language, it gives you some of that cultural knowledge in order to make sure that you're making everybody feel comfortable. I will also say that, this training is not something that you check and you're done. Training is something that's ongoing. So it's something you need to reevaluate on a regular basis to know whether or not you're doing the right things and you're reaching people.
Just to reemphasize medical mistrust and how it can affect our patients, this is a reflection of the historical and ongoing injustices by socially and economically marginalized groups. So they will be more likely to be utilizing healthcare at a lower rate or have poor management of healthcare conditions. There's a myriad of negative consequences, but rather than addressing the medical mistrust as a phenomenon, it's important to consider that it was, created in these systems that reinforce societal stratification, racism, classism, homophobia, transphobia, and stigma. Looking at ways that, we can stay up to date with respect to the changing legislation or advocacy in our field, and particularly those, as Dr. Harewood had mentioned, when we're looking at cultural humility, looking at the training that we might have, that might be required for our licenses, there are resources online, including the AOA Public Health Policy Institute, your local state-led organization, and then continuing education. Of course, continued familiarity with the current legislation is important and benefits us as we know what gaps our patients might be experiencing in their care. And Dr. Harewood will go over it now.
So there actually is, as most of us may know, a proposal to expand Medicare. And I'm not sure how many people are aware of this, but it's a proposed bill that significantly expands Medicare Part B coverage, so it can actually affect our practice quite a bit. And the proposed expansion includes an annual refraction and contact lens fittings. And one big thing, it would actually provide coverage for materials. So up to $100 for one pair of glasses or for 1 year of a supply of contact lenses. And that materials benefit would be through Medicare's Durable Medical Equipment Program, which actually would help to reduce the likelihood that, they could have predatory insurance or predatory programs that would, provide inadequate materials. Now, this is something that has been introduced. It has not been passed. It's part of the large infrastructure legislation that's being proposed by the current administration. But it could mean a lot of improved access for us. This is why we need to be part of our legislative organizations and help to stay informed so that things like these can pass. And so in order to stay up to date on whether or not this will pass, just keep up to date with your legislative organizations. And I think we put some of those resources also on the previous slide.
So looking forward, we touched on all the barriers that were listed by Pinchansky and Thomas. But this, presentation and some aspects of it really came at the end of my residency time when I was thinking about what can I do outside of the exam room, or what, where am I supposed to fit in these other problems that patients may have. And honestly, doing this presentation and working forward, as we talked about with the resources that we have available, one final barrier to eye care that was argued by Russell et al. Is actually physician awareness. So continuing education, taking the time to learn more about our field and how it relates to our patient allows us to provide better care. As they stated, awareness through effective communication enables consumers with an understanding of their health issue that should be met by the competencies of their provider to meet their need. So this helps us kind of better to equip to prepare to address their needs. So let's quickly review kind of what we discussed throughout the presentation today. Looking at the social determinants of health as defined by Healthy People 2020, they include a patient's neighborhood and built environment, their education or access to education, relationship to education, economic stability, their social and community context, and then finally where we fit into the puzzle, health and healthcare.
We also spoke about optometry as part of the comprehensive healthcare team, how we are the primary eye care providers, often the gatekeeper to the healthcare system, and how important that is, how we collaborate with others, and our collaboration can help people better access care, how our visual outcomes are directly related to quality of life, so how important us providing this care and quality care is, and the fact that our scope allows for medical management, which further encompasses the healthcare team environment. We also spoke about some of the different ways we can think about access to care, whether that be personal issues, provider issues, and system-wide issues. And we really delved into how we try to get beyond some of these issues to provide the care that we want for the patients that need it.
The other Penchansky and Thomas classification, affordability, accommodation, availability, accessibility, acceptability. We went through practical approaches and ways and resources that we can use to help our patients. And finally, physician awareness, probably most impactful.
So if we can just go through the takeaways that we want for you to think about, it's really to think about how important optometry is for caring for underserved populations, review the barriers and access to care, which I think we did extensively, and really to outline solutions to overcome those barriers. Now, we definitely provided a lot of resources and gave a lot of information. So Dr. Tadapuli was nice enough to put together all of these resources on a resource sheet with links that she's going to put in the chat at the end, so you can download it for yourself and you can see or access some of the resources that we mentioned. Anyway, we also want you to recognize personal versus provider versus system-wide issues. We want you to be aware of practical approaches to improve care, and also it's a constant process. So in terms of knowing all of these different things that are available for your patients who may have trouble accessing the system, this is something that I interface, and I'm sure all of us interface with it all the time. And in order to stay up to date, it requires us to really make an effort to do so. And that is really going to help our patients, and it's going to make the ease of our care much better and improve access for all. So thank you very much. We are very happy to take any questions that you have, and we'll put that resource in the chat box for you.
Thank you so much. I'm going to stop really quick just so I can upload everything if anybody wants to take over. But yeah, feel free to keep the questions coming and the discussion going.
I also wanted to mention one thing before we leave, and it's one thing that I actually mentioned this weekend that I thought was something that we were taught, but I don't know if it's something that was widely disseminated. And it's a little bit off topic, but I think it's important and it relates to this presentation. So in terms of treating uveitis, we think about spondyloarthropathies, so like HLA-B27 related diseases. There was a time where one of the diseases that we think about, we would call it Reiter syndrome. And we now call that reactive arthritis. And that's what we should change when we teach. And that's what we should change when we talk to patients. The reason being, Reiter was actually a doctor who was involved in, administering some of the terrible things that happened in the Holocaust. And he is not somebody that we want to evoke. So when you're thinking about Reiter syndrome, if it's something that you think about or talk about, you want to call it reactive arthritis. Kind of off topic, but kind of on topic. So just something to change in your language. And language is always changing. So if that's not something that you knew, that's completely fine. Just make sure you try to stay up to date with that.
I think we have one question in the chat. I can read it for you. Okay. So what do you think the most important social history questions we should ask regularly as a part of our optometric exam?
Well, I would say first ask what pronoun that your patient would like to be called by. And then in terms of their social history, I think getting to know their visual needs and really getting to ask, what I think it also depends on how the patient approaches you. In your regular exam, in terms of social history, you may want to ask the patient, how their access is to care, or if they have an issue accessing care. That's what I would say. And if they give you any information about that, then you can make further referrals or recommendations from that. Do you have any other recommendations? Okay.
All right, so I don't see any other questions in the chat. Thank you, Dr. Tadapole and Dr. Harewood, for an amazing lecture. And thank you everyone for attending. I'm gonna go ahead and end the lecture. Did you have any?
Have you guys hold on for just 1 second to add that little resource list, and then we'll be all set. Thank you.
And if we can't get the resource list in the chat, we can also provide it to the Office of Continuing Professional Education to send out at the end to the attendees. So whatever is the easiest is fine.
Yeah, I think that might be easier.
Okay. So thanks to everybody for attending, and Bridget, feel free at any time.
All right, thank you everyone. Have a good night.